This is Dr. Dinesh Kaul from Sir Gangaram Hospital, Institute of Child Health. We are gathered here again for a PG class. We have been doing this sort of exercise, both the guest lectures and the online classes for postgraduate students of both DNB and MD, so that we can help them out to clear their examination, the practical examination, and to hone their clinical skills. So this meeting was, in fact, started by Dr. Anupam Sachdev, the director of the Institute of Child Health, way back following the onslaught of COVID. So we have been continuing these meetings for the last 5 years or so. So a good coordinated support from the Delhi IAP and the accredited national board institutes, various institutes which are accredited to the National Board of Examination. So with support of this, we are holding these meetings. So this Wednesday, we have a postgraduate class, a session about a clinical case presentation by Dr. Vasudha. She is our second year postgraduate student, third year postgraduate student,
Second year, sir.
second year postgraduate student in the Department of Pediatrics, Institute of Child Health, Sir Gangaram Hospital. So she is going to highlight an approach to a little day-to-day. You may see it in your clinical rounds, in the ward rounds, about various anemias, be it hemolytic anemia or an iron deficiency anemia, with a severe form of anemia, who may not have required transfusion, but may have other multisystemic disease involvement. So go ahead, Dr. Vasudha.
Okay. Thank you so much, sir. Good evening, everyone. So let's go ahead with the case presentation. So this is patient ES. She's a 14-year-old female child who is a resident of Calcutta, West Bengal. She is a Hindu by religion. Informant was mother and herself. The date of admission of this patient was 3rd of July 2026 and the date of examination was 6th of July 2026. The chief complaints that the patient presented with were generalized weakness since 7 months, joint pain since 6 months, decreased appetite since 4 to 5 months, blood in stool for 1 week duration, which was about 4 months back. Then the patient had rash and swelling around eyes about 3 months back. She had fever for 1 week, 3 months back, pedal edema and facial puffiness 3 months back, pallor since 3 months, hair fall since 3 months, and oral ulcers, which was 10 days back. So the patient was apparently well until 7 months back when she started complaining of generalized weakness, which was gradually progressive in nature. Initially, the weakness did not interfere with her routine activities, but over time it worsened and began affecting her daily activities also. About 6 months back, she developed pain in wrist joint and small joints of hand, and she also had pain in the knee joint and shoulder joints. The pain was bilateral, intermittent initially, and later became more persistent. It was associated with morning stiffness and difficulty performing routine activities. But there was no history of any significant joint swelling, redness, local warmth, deformity, or any restriction of movement. Around 4 months back, she also experienced passage of fresh blood in stools, which was lasting for approximately 1 week. The bleeding was not associated with any abdominal pain, diarrhea, tenesmus, vomiting, or constipation, and resolved spontaneously. For the last 4 to 5 months, she had decreased appetite and history of 3 to 4 kg of weight loss in the last 3 to 4 months. There was no history which was suggestive of dysphagia, recurrent vomiting, or chronic diarrhea. Approximately 3 months prior to admission, she also developed a periorbital rash, which was associated with hyperpigmentation. The rash was also present in the temple area and behind the ears, and most of the rash has resolved by now. but it was not associated with any itching or redness. Moving forward, she also complained of excessive hair fall for the past 3 months, which was diffuse and it was progressive. 3 months prior to admission, she had an episode of fever, which was lasting for 1 week. This fever was low to moderate grade, intermittent in nature, and was not associated with chills or rigors, cough, burning micturition, or any obvious focus of infection. During the same period, uh, parents noticed facial puffiness and bilateral pedal edema, which were initially mild but progressively increased over time, which lasted for 1 week. There was no history of oliguria, urine, hematuria, or hypertension documented at that time. During the course of illness, parents also noticed progressive pallor. For all these symptoms, child initially visited multiple local hospitals, but later she was referred to a higher center. So evaluation done at a higher center revealed very low hemoglobin, for which she received 2 units of packed red blood cells. And the evaluation after evaluation, she was also told to have a blood-related disorder which may require transfusion. Parents were also evaluated for the same condition, and mother was told to have a similar condition. And patient was hereby referred to SGRH for further evaluation. There
Okay,
was no yes,
okay, wait. Let's go back to your presenting complaints. So your chief complaints are generalized weakness for about 7 months. Okay, so
yes,
7 months prior, this girl was okay, 14-year-old girl, okay,
yes, sir.
was perfect. So was she going to school? Was she doing her normal
Yes, sir.
household?
Mother
Play?
reported that
Okay.
academically she was doing fine.
In which class is she studying?
Sir, in class 10th,
10th. She is a 14-year. Okay, she is studying in 10th. She was okay. So she started with a. What do you mean by weakness? If I say
uh,
generalized weakness, does it mean
generalized weakness.
lassitude? Does it mean muscle myopathy sort of thing? What does it exactly mean?
Sir,
She was
generalized
having
weakness.
pain in the muscles or anything in the body?
No, sir. The patient had been complaining of having a low energy.
Okay.
Um,
She was having lassitude. See,
yes,
possibly
sir.
was having lassitude. She was having. So, what could be the various reasons for generalized weakness?
Sir, generalized weakness for an adolescent girl, one could be anemia, could be
Yes.
one of the causes. Hypothyroidism could be a cause. Then, in this age group, maybe a psychological cause like depression or anxiety may also be causing
Okay.
generalized weakness.
Fine. There is no fever or anything like that. There is no antecedent earlier, any URI that she had some. You think this is a viral
Yes, sir. So,
myositis.
post-infective, also there can be generalized weakness,
So
but there was no such
there was no infection. So
history of
you think
viral
that she
prodrome.
had weakness. So possibly could it be due to anemia? So if you go through the history again, okay. Joint pains. Okay, I think my voice is echoing. Joint
Yes,
pains for about 6 months.
yes, sir.
Decreased appetite 4 to 5 months. Okay, so the generalized weakness, decreased appetite, both can be attributed to anemia. Okay,
Anemia. Right,
then
sir.
blood in the stools, 1 week
Yes, sir.
duration. So
Yes,
we
sir.
cannot attribute it to anemia. This is anemia. This could have led to anemia. So if
Yes,
she is
sir.
having obvious, okay. So what are the various causes of blood in the stool in an adolescent girl?
In an adolescent girl, firstly, it will depend on the nature of the blood that is in the stool. If it is a fresh blood, then my first differential would be to look for local causes. For example, hemorrhoids or strictures. Other than that, so the patient could be, if it is dark colored blood, which we call melena, then
Okay.
mostly upper GI causes. So she could be having a peptic ulcer disease, since she's having so much of
So
weakness
we'll
and
ask
decreased.
her basically what is the color of the blood?
Yes, sir.
Is it is it a fresh blood? It is an
Fresh blood.
old type of a blood? Is
Yes,
it
sir.
blood with mucus? Okay.
Yes, sir.
Because everything then will change. If it is a stool admixed with mucus and she is having tenesmus
Yes, sir.
and possibly she had some fever also, so we might think of there's a bacillary dysentery going
Yes,
around.
sir. Could
But
be.
okay, any painless bleeding, okay,
Yes, sir.
bleeding after she passes stools. So you might think she had a fissure. Because of her chronic constipation, she has developed an anal fissure. So it's very important to look what are the various causes of blood in the stool. Okay.
Yes, sir.
This was a painless bleeding
Yes, sir. It was painless bleeding and it was fresh blood.
and
And
fresh.
there was a small amount of blood with every stool and it
Okay.
resolved spontaneously.
Fine. So without any
Less
medical.
likely a local cause like hemorrhoids or anal fissure because that would have caused pain. And
Okay.
then most likely located to lower GI because the
The
blood
fresh
was
blood, it
fresh.
is primarily an hematochezia.
Yes, sir.
So what is the difference between hematochezia and melena?
Hematochezia is a passage of fresh blood, and melena is the passage of uh, uh,
Dark,
dark
reddish,
blood, which
brownish
is
blood.
digested, basically
Yeah.
broken down by the stomach acid.
So what if you put some water over the melena
Yes, sir.
stone, so it will change its color back to a little bit of an red. Okay, so
Yes,
that's
sir.
the typical how you check for the fine.
Okay.
Then she had rash and swelling around the eyes. This is
Yes, sir.
about 3 months back. And for how long
Yes, sir.
did this was an evanescent rash? She was having rash,
Um,
it would subside.
yes, sir. The rashes were insidious in onset, and then they lasted for about 10 to 15 days, and then they started. Uh,
Was it over the malar area, the
no,
cheeks,
sir, it was not
the
involving the malar
butterfly
area.
rash?
It
No.
was a no, sir. It was a papular, not small,
Was it an
vesicular.
erythematous rash or just a
No, sir.
papillary rash?
It
It
was
was
just a
reddish.
papular rash with which was hyperpigmented. It was not reddish. There was no erythema. So
Okay.
it was hyperpigmented. And currently also the patient has some rash in the postauricular area, which still
Okay.
has the hyperpigmentation and some visible scaling as we will discuss subsequently in the examination slide.
Fine. Fine. Then fever.
Yes, sir.
How long did she get it? It was an intermittent type of fever because that's very important. If she's getting a low grade type of fever, that means it's possibly is it an infectious
Infective
or is it
cause.
a non-infectious type of an thing going
Sir,
around?
so the fever was acute.
Okay.
It was for lasting for about 6 days, 5 to 6 days, and she used to get 1 to 2 spikes per day, and there was no localizing sign along with fever. So
Was
we
it
don't have,
mild? Was it mild grade, moderate grade, high grade fever?
sir, we can say moderate to high grade fever.
Moderate to high grade fever. Okay. Then pedal edema. She had an pedal edema and facial puffiness. Okay.
Yes,
So
sir.
what about her urine output? Was it low? Was she getting polyuria? What about her breathlessness? Was she getting breathless on exertion?
No, sir. There were no such complaints. There was no complaint of reduced urine output. So I asked this in view of nephrotic uh,
Okay.
perspective. So the patient did not complain of reduced urine output or frothy urine, or and she also did not had any shortness of breath or cyanosis or
So that means that possibly the cardiac system or the
is
lungs, the pulmonary system is not involved in this.
yes, sir.
So if she is not, either you have to have a cardiac manifestations, okay, or you have to have a renal system which is being involved, or the chest which is being. So it looks like
Yes, sir.
possibly her lungs are relatively fine,
Yes,
and
sir.
she has been having pallor for about 3 months.
Yes, sir.
Okay. So that's it. How did you check that she was pale? The mother said that she was having her color, skin color had changed or something
Yes,
like
sir.
that. How do you
Yes, sir.
really elicit the
Uh,
history of pallor?
On the basis of history, the mother said that the relatives around her had been telling her that your child is getting pale day by day.
Hmm.
Since the mother was living with the child every day, so she herself could not notice it at
Okay.
so much abruptly, but she was told by the relatives, and then she came to realize that yes, the child is getting pale.
Okay. Fine. Then hair fall. Yeah.
Yes,
Fall.
sir.
Okay. So hair fall for about, so if you have an excessive hair fall, so that worries us that does
Yes,
she
sir.
have a chronic disease?
Yes, sir.
Fine. Then oral ulcers for about 10 days back before she,
Yes, sir.
okay. Fine. Were they painful ulcers or non-painful ulcers?
Sir, sorry, I'm not sure about it.
Okay. So that's because if she had very painful ulcers
Mhm.
and it was having recurrent ulcers, it would
Yes, sir.
mean that they could be
Dishes.
even aphthous ulcers, or
Yes,
if
sir.
she had fever, she develops an ulcers. You might think of
Hmm.
has she picked up an enteroviral type of recent infection.
Yes,
So
sir.
we need to see the ulcers in context of the rest of the findings. And
Yes, sir.
joint pains. Joint pains, did she have some joint swelling also?
Yes, sir. Mother reported that there was some joint swelling and
Okay.
she had morning stiffness also, uh,
So,
which
okay. So
resolved
that takes us where? That takes us to the
inflammatory
collagen
cause of,
vascular disorders.
yes, sir.
Yeah, so that goes that, so we may move a little bit from the infective causes then to the collagen vascular disorders, if this
Yes, sir.
is your sort of the chronology of history. Okay, go ahead. Where we left.
Yes, sir. Yes, sir. We were discussing the negatives. So, there was no history of bony pains, neck swelling, night sweats, or recurrent fever, photosensitivity or behavioral changes. Then there was no history of proximal muscle weakness like combing hair or standing up from a chair, abdominal distension, frothy urine or decreased urine output, epistaxis, gum bleeding or petechiae, bluish discoloration of toes, ear pinna on exposure of cold, FICA, photosensitivity, or seizures or focal neurological deficits.
Okay.
On the
So
other than,
if you move to the, if you negative history, you had something specific. Bony pains, you
yes,
were
sir.
thinking of what? Possibly
The
there was trying
malignancy,
to
I
do
was,
leukemia. She didn't have any underlying leukemia. Neck swelling and night sweats for the lymphomas.
sir,
Hodgkin for the
tuberculosis,
non neck swelling, night sweats. Okay, for TB. Why not
yes, sir.
lymphoma? Why not Hodgkin's
Yes,
or
the
non-Hodgkin's
lymphoma can
lymphoma?
also have
Okay.
night sweats.
So but you're in the history, you are not presenting any discrete swelling. So that's a little down on the line that she may have a lymphoma. But a child of this age group may have a Hodgkin's lymphoma, non-Hodgkin's lymphoma. Okay.
Yes, sir.
So with a neck swelling, with night sweats, with hectic variations of fever, so that
Yes,
could
sir.
be a manifest with anemia, could be a manifestation of Hodgkin's, non-Hodgkin's lymphoma.
Non-Hodgkin's lymphoma.
Okay. Photosensitivity. So photosensitivity would go in favor of what?
Autoimmune causes like SLE or
Okay. And behavioral changes.
ADM. Sir, again for psychosis component of the autoimmune conditions like
Okay,
SLE.
fine. So neuropsychiatric manifestations of
Yes, sir.
acid. Okay. Then proximal muscle weakness. So did she
Sir,
have some myopathy underlying?
yes,
What
sir.
type of myopathy?
Juvenile dermatomyositis conditions have predominantly have proximal muscle weakness. That is why I particularly asked for these two histories.
Fine, that's okay. So there's no epistaxis, there's no gum bleeding, there's no petechiae. Okay, so if
So
had
since
she
she
some
had,
epistaxis or
yes,
gum
sir.
bleeding, petechiae, so what
Sir,
that
I
will
would
tell
think
us?
of thrombocytopenia. That would suggest that the child
Okay,
is having thrombocytopenia. So then I
okay,
will evaluate in that
thrombocytopenia maybe
direction.
because of an ALL, because of an
Yes,
AML at this age, you can have an AML also,
yes,
or
sir.
because of any other cause leading to low platelets. Okay, fine. Then bluish discoloration of toes, ears, pinna. Okay, so what you're trying to look at this?
Um,
What happens in the Raynaud's phenomena?
Raynaud's phenomenon, sir, there is a um,
So there's a
tricolor
vasospasm.
response. Yes,
So you
sir.
have a
First there
vasospasm
is,
of the
yes, blanching, then redness, and
branching.
then,
So they
yes,
have
sir.
a severe vasospasm. If she would dip her hands or into the feet in the cold water, they get a very severe vasospasm. So that's
Yes,
also
sir.
manifestation of certain vasculitis or autoimmune conditions. Fine.
Yes, sir.
Pica. So why pica?
Sir, since she's complaining of generalized fatigue, generalized weakness, pallor, so I was
Worm
iron
infestation.
deficiency anemia could be the cause for a lot of the presenting complaints. So that is why
Well, I would think of if what is trichobazor?
is a condition where the patient eats hair.
Out of hair. So there's a psychiatric condition. They will take unedible things. So if
Mm.
she has some psychiatric manifestations, so she could be that could be the reason for having a
The,
pica also. Okay.
but there is a patchy hair loss in that case.
Okay.
But here the hair loss was diffuse.
Okay, not about the hair. Okay, the pica, I'm telling in the if she has certain psychiatric conditions like an anorexia nervosa or
Yes, sir.
bulimia, which could be she could have a pica as a as a
Mm.
part of that, but it doesn't
Yes,
look
sir.
like that.
Yes, sir.
Okay, so in this case,
Yes, sir.
photosensitivity, no photosensitivity,
Yes, sir.
fine, and no seizures, no focal neurodeficits. Go ahead.
So, other than the current presentation, there was no history of similar complaints in the past. The child had been perfectly fine, and there was no past history of any blood transfusion.
Okay.
Antenatal history was uneventful. Birth history, the child was calm, normal general delivery, 3.5 kgs. There was no NICU stay, no neonatal jaundice. Breastfed for 1 year. Complementary feeding was started at 6 months of age, and
Mhm.
perinatal history was also uneventful.
Does a birth
Child,
history have any relationship, this sort of an with a 14-year-old girl who she doesn't have any CNS manifestations, no developmental delay or anything like that? Does do you have
so
something
if the
in
child
mind?
has had any history of neonatal or let's say infantile jaundice, then I would suspect
Hmm.
and I would look for a stigmata of CLD in this patient because a lot of complaints can be
Hmm.
explained by the same. Um, Other than that, sir, I would also look at this thing in from perspective of a hemolytic anemia, for example, thalassemia.
Hmm.
So even in that case, the child would have had complaints of pallor and requirement of blood
Right from
transfusions,
early
especially in the
age.
growing age.
Early age, yeah.
Yes,
Somebody
sir.
has put a question that why are we asking the history of seizures? Okay. So somebody has some attendee has put anonymous person has put in question that why are we asking history of seizures?
Neuropsychiatric
It's very
manifestations of
important, yes,
SLE.
for neuro. So we have to, if we're thinking of underlying autoimmune problems, the systemic lupus erythematosus, CNS manifestations are one of the components in SLE. And in fact, in the Indian children, you have severe form of the neurological manifestations and the renal manifestations of SLE. Okay. Fine. So, as such, birth history may not be very relevant in this. This is just as a part of protocol. Had it been a 2-year-old child, 3-year-old child with some developmental delay, I would have thought, no, definitely, I need to ask the birth history. Okay, go ahead.
So the child was immunized till 10 years of age as per NIS,
Mhm.
and immunization card was not available.
Okay, so what do you expect she should have got by 10 years of age?
So there is a booster dose of tetanus that is given at 10 years of age.
We don't
Uh,
give only tetanus, we give DT
TD.
in the
Yes, sir.
national
Yes,
program.
sir. Yes, sir.
TD, okay, small
TD 15
t,
and
big
tetanus.
T, okay. So that's in the national program, but in the IAP, for the rest of the CDC or the IAP recommendations are to give DTAP as
Yes,
an
sir.
adolescent DPT, okay. And immunization card is not available. Fortunately, these days, what we have is that every immunization card is being digitalized by the National Immunization Services. So most of the children who come to government as well as private, I mean, in the government who have the access to the National Immunization Services. So their record is being maintained in the computer, so even the parents can download their immunization status at any point of time.
Okay.
Okay, go ahead.
Sir, also the guidelines say that HPV vaccine should also be started by 9 years of
HPV
age
should
to
be at 9 years of age. Okay,
get that also.
fine.
Sir, so maternal aunt and grandmother had a history of abdominal surgery, which was probably the removal of gallstone. Other than
Okay.
that, there is no history of any blood transfusion or blood-related
No
disorder.
relative is getting any regular blood transfusion that we think that they may have a sickle cell type of a disease or an thalassemia or any thalassaemic syndrome, thalassaemic intermedia.
Yes, sir.
So fine, that's okay. Go ahead.
Sir, this is the dietary history on the basis of 24-hour recall method. On the
What's her
basis
weight? What's her, sorry, by the way, what's her weight
sir,
before you move?
45 kg.
She is okay, it's 45. I was just trying to see the calories. Okay. 45 kgs. Okay.
Yes.
So for 45 kgs, this girl is consuming around 1185. Okay.
Okay. Yes, sir.
So, what is the dietary recommendation for this is a sedentary worker? Do we think this is a sedentary worker?
Yes, sir. We can say that.
So, this is basically a pediatric age group.
Mm,
So, she is in the pediatric age group. So, we'll have to look at the ICMR recommendations. Okay. The dietary recommendations, they both for calories and the proteins for
proteins.
this. So, what is the approximate protein requirement at this stage
Sir, 1.5 grams of protein per
per
kg of the body
kg?
weight.
So, I
And
would expect she would say, even if I say 1 gram, that would be around 45 grams of protein she
yes,
should
sir.
be getting
Yes,
daily.
sir.
You have said 46 grams.
Sir,
So
yes, sir. This
normal recommendation is around 1
is,
gram per kg of protein. Okay.
yes, sir.
Calories you have mentioned around 2000 because this is a growing
70%. Yes, sir.
adolescent post-pubertal child. Okay. So your recommendation, so she is falling about 41% deficit,
Yes,
both
sir.
so in the calories as well as in the
Proteins.
proteins. And what should be her 45? What should be her expected weight at 14 years?
Sir, expected weight should be somewhere around 50 to 55.
Approximately more than
Yes,
50 kgs.
yes,
Okay,
sir.
fine. Okay, we'll move to the physical examination. I was just trying to, so now she has both, she is deficient in the calories
Calories
as
as well
in
as
the
in proteins.
proteins. And do we
Yes, sir.
know the weight pre-illness? 7 months earlier,
Um,
do we have any idea if you have, if they have been to a physician and
The mother reported that there has been about 4 kg weight loss
so
in
drastic? Okay,
past
so that
6 months.
means I would expect she was 49, 50 kgs
Yes, sir.
pre-illness. Okay,
Yes,
and
sir.
she has lost a
About 5
significant
kgs.
amount of weight,
10% of weight.
10% of the weight in last 7 months. Okay. So, okay, go ahead, summarize the whole thing.
So this is a 14-year-old female child who presented with complaints of generalized weakness in 7 months, joint pains in 6 months, with a history of fever, rash, and swelling around eyes and blood in stools 3 months back, and also has progressive pallor and with anemia that required blood transfusion and oral ulcers with no significant birth or developmental history.
Okay. By the way,
So,
what's her date of birth? Did you check her date of birth? The
no, sir,
parents?
sorry, I am not sure
So
about the
it's
date of
very,
birth.
I would suggest all the attendees that
Okay, sir.
once you are taking a clinical scenario in the pediatric to calculate the exact age, you should ask the mother the date of birth. Most of
Okay,
them
sir.
will come with the exact date of birth. Okay. So that helps. She could be like 14 years, 11 months. Like
Yes, sir.
she could be technically 15 years, and your weight will definitely deviate on the
Yes,
nomogram.
sir.
So you should be very particular and specific to ask the date of birth. So that
Okay,
gives
sir.
you the exact age. Okay.
Okay, sir.
Fine. So now you have this 14-year-old girl who has presented with generalized weakness, with joint pains for about 6 months. She has a history of fever, moderate grade fever. She has a rash which subsided of its own. And then there was an episode of few episodes of blood in the stool about 3 months back. Main issue is that she has been having progressive
Pallor.
pallor. Okay. Pallor with anemia. What does it mean?
So pallor with a documented anemia that required a
Okay,
blood
that was.
transfusion.
So she has been having, from historically, she has been having pallor. Yes, definitely she was anemic. So they are more or less for synonymous. Okay.
Yes,
So
sir.
that required blood transfusion. She has also history of oral ulcers. Okay. Now, where are we in this scenario?
So,
What do you think she has?
on the basis of
Without
the
getting biased with your diagnosis.
Yes, sir. So, given the multi-system involvement and the nature of the presentation, the first
Okay.
differential that would come to me is an autoimmune condition. And since the child is a female adolescent, my first differential would be an SLE.
Mhm.
The points in favor would be that she's a female adolescent, then she has oral ulcers, she has joint pain, she has rash. Then, secondly, we could think of other autoimmune conditions like radium, which also has rash, joint pain, oral ulcers, GI blood loss, arthritis, fevers. But then, not the proximal muscles are not involved, so that is why this condition is a bit less likely. Then I can think of a small vessel vasculitis because again, uh, sorry, the alignment has a bit
Okay, okay, that's
is been
fine.
disturbed. So a small vessel vasculitis, again, the GI blood loss, arthritis, fever, fatigue, rash, and oral ulcers go in the favor of small vessel vasculitis. Patient could also be having tuberculosis, uh, like because she's having blood loss, fever, weight loss, joint pain. But then the rashes and the oral ulcers cannot be explained by tuberculosis. Patient could also be having an inflammatory bowel disease because she has bleed, rash, fever, weight loss, oral ulcers, and constitutional symptoms. But um, I would like to further examine to confirm my findings. And patient could be having thalassemia because she has had anemia which requires blood transfusion, and there was a history of similar complaint in the mother as well.
Okay. See, the thing is that she has not primarily presented with lot of fever. Had she primarily the first presentation was she has been having off and on fever. Okay.
Mm.
And with anemia. So I would really think that no, are we dealing still with the TB? Okay, or are we dealing with the lymphoreticular malignancy in
Mm.
leukemia, which
Yes, sir.
she has not been evaluated. No CBC has been done till this point of time. So that, uh, but since she is a female child, okay, and then female adolescent with rash, with joint involvement, with fever, which is off and on fever. We don't have access to the labs at this point of time. Uh, but there are no CNS manifestations. You don't have a typical butterfly rash, malar rash. Okay. So, but still, you don't have any evidence of nephritis. So you may, it's a little open situation that what you would, so then only your physical examination and some investigations will definitely help us. But TB still remains very important, all said and done. Sometimes we think of lot of, it's very important that yes, we do overdiagnose TB, but TB still remains quite high on the cards for most of the Indian children often. So we need to rule out, get their at least a chest X-ray done, get them a tuberculin test done, and rule out definitely TB before we move to other disorders. Okay, go ahead. I would
Yes,
think
sir.
of it. Does she have? She's not from a sickle cell belt. She's not from Orissa. She's not from
Madhya Pradesh,
Madhya Pradesh.
Maharashtra.
So if she had a severe anemia, she required transfusion on few occasions, and the doctor said that no, she requires frequent transfusions. So I might think that no, does she have underlying and hemolytic type of an anemia? Is it a sickle cell anemia? Is it something like a thalassemia? Is it an E beta thalassemia?
Yes,
Or
sir. Could
is
be.
it a full blown sickle cell disease? So everything needs to be so,
Yes,
but
sir.
definitely, I do agree with your systemic lupus erythematosus as your first. JDM, I would put little down on that they are less sicker children
Okay.
who have JDM, okay? And then small cell vasculitis is definitely important, but TB, I would still
Yes, sir.
consider
The
and
current
reconsider
currently the
before I.
presenting complaints are not in alignment with TB, but given the burden of TB, we always have to
Should
consider
like
as one of the
the
different.
fever, with anemia, with the bleeding, lower GI bleeding, it's possible she may have an. Could it be an IBD? I would think
Yes,
a
sir.
TB or IBD could have very mimicking presentations from the
Yes, sir.
GI point of view. Okay, go ahead.
Okay, sir. So, sir, I would like to proceed for the examination. So examination was done after taking parental consent, and it was done in supine position. The pulse rate was 108 as measured in the right hand. There was no radial, or radiofemoral delay, and it was normal in volume and character. Respiratory rate was 26. SpO2 was 98% on room air. Peripheries were warm. Temperature was 98-degree Fahrenheit in right axilla. Peripheral pulses were well felt. CFT was less than 2 seconds. So the pain score was uh, normal. And so blood pressure was around 100 by 70 as measured in the right arm in supine position by digital sphygmomanometer, which is between 58 to 90th centile.
So how do you grade the pain score? So if I were to grade from 0 to 10, so what would be, so that's what is this called? What is the name for this pain score?
So the visual analog
Where you
pain.
make those smileys, and so
Yes,
that's
sir.
the typical smiley faces.
Yes, sir.
Visual analog scale.
Visual analog
This
scale.
is
Yes,
a
sir.
typical visual analog scale, which most of the you can do it in infants with the other children with adults also on the basis of their facial expression. So you can visualize what is the amount of pain. Okay,
Yes,
so
sir.
maybe it would be just 1 or 0 would be the pain score. So high,
Yes, sir.
as you go high up, the pain score is more.
Yes,
Okay,
sir.
so anthropometry, you are telling us that she is 45 kgs, and
Yes, sir.
this is between the 25th and 50th centile. So
Yes,
you
sir.
should have the 50th percentile as a mark. Okay, so now what is this chart? This is
So
a
this is a
combined WHO
IAP
and
growth chart.
an IAP growth chart
Yes,
from
sir.
0 to 18 years. So
Yes, sir.
okay, so at the 14 years, you are telling me she is around between 25th and 50th centile. So her 50th centile works out to be around, it works out to be around, it looks around, it is around,
The
it's around
50th centile for
40,
her
looks
weight,
around 45 but
50 to 55 somewhere.
yeah, it looks it's around 45 from, but anyway, fine.
The 45 is her
I would
weight.
expect that, see, if anyway, if I take it looks from this is the 45 for your, it is 45 is the 50th centile on your chart for a
Yes, sir.
14-year, but if she's a little more, anyway, that's fine. So you are thinking that you have calculated this is between 25th and 50th centile. Fine.
Yes, sir.
Okay, and height,
Height was around 161 centimeters, sir,
that's
which
okay.
is at 50th centile. Yes, sir.
Okay. Is she has post menarche?
Yes, sir.
Okay, fine.
Coming to head to toe examination, the
Okay.
child had pallor, as I could see in the lower palpebral
So
conjunctiva.
if before I move out, before I go to the we go to the next slide, if I don't have access to the growth charts, okay, so do you know the formulas how to calculate weight and height?
Yes, sir, there is this Veach formula.
Vex
Uh,
formula.
yes, sir,
This is
which
the
says
Vex
that it
formula.
is for different for 0 to 7 years, 7 to 12 years, and more than 12 years
It is
of.
great. Basically, Vex formula will, if you look at the previous editions of Nelson, about
Mm,
2 or 3 editions, you will have the Vex formula. Okay. So if I remember from the height, the best thing
yes, sir.
is age into 6 plus
Plus,
77. Age into 6 plus 77. So this will
yes,
be
sir.
the height in centimeters, and this is applicable for 2 to 12 years age only. Okay.
Okay.
So because after 12 years you get a pivotal spurt. So this
Yes,
formula
sir.
is not applicable after 12
After
years,
pubertal
both in
spurt.
boys as well as girls. So you will have to use the growth charts. Fine. Go ahead with the examination.
So, sir, proceeding forward with the head-to-toe examination, the child had pallor, which was well seen on the lower palpebral conjunctiva.
Okay.
There was no icterus, no cyanosis, or no lymphadenopathy. There was no pedal edema,
So is this
um,
mild, moderate, or severe pallor?
mild pallor, sir.
Because she has received transfusion.
Yes, sir.
Fine.
If it was moderate pallor, then it is seen on both conjunctiva and the nail beds. And if it is severe pallor, then we can see it on the oral mucosa as well.
Fine.
So, so the patient had sparse hair. The nails were normal. There was no facial edema. There was no nosebleed or nasal discharge. There was the oral cavity was dry. There was no cheilitis or oral ulcers. The dental hygiene was good. There was no caries or gum bleed. Then on the ear there was a post-auricular rash with hyperpigmentation, and there was no ear or bleed or discharge. This is the image of the rash.
Posterior auricular rash.
Yes, sir.
So what is the scale? Is it something like a scaly rash?
Yes, sir.
There's
Hyperpigmented.
so there's an hyperpigmented. It looks like as if this is like an atopic dermatitis. Only there is some bluish discoloration over here.
Yes, sir.
Okay. Fine. So it looks more of it's like a seborrheic type of an dermatitis, which is at the back of the ear, which I can see. Okay.
Yes, sir.
There is no malar rash. There is
No,
no
sir.
any discrete
But no
butterfly rash
butterflies,
on the face.
red
Any
pattern,
any
and
discoid rash, any
no, sir.
discoid lesions over the skin?
No, sir, none.
No discoid. Fine. So
Coming to systemic examination, first is per abdo. So there was no abdominal distension, scars or visible peristalsis or pulsations. There was no local rise of temperature. Liver was palpable about 4 centimeter below the right costal margin in the mid clavicular line with a smooth surface, regular margins, and firm consistency, and it was non-tender. Then the spleen was palpable about 2 centimeter below the left costal margin along its axis. And it was also firm and non-tender with a smooth surface and a palpable notch. And it was also moving with the respiration. And there was no other organomegaly or abdominal mass that was palpable. There was no evidence of ascites. Liver span on percussion was 16 centimeter and bowel sounds were heard. Central nervous system, the findings were all normal, sir. So was the cardiovascular system and the respiratory system. I would like to move forward to the skeletal system, where there was mild swelling and tenderness, which was present over the bilateral DIP and PIP of all the digits and bilateral wrist and ankle joints. But there was no joint deformity.
so only swelling and tenderness present all over the joints, or the skin, or the muscles were
No, sir, there was
swelling.
no muscle tenderness.
Okay.
There was no skin changes over these joints.
But so where is the swelling? Where is the swelling or the tenderness then present?
Sir, on the joint
On the
surfaces.
joint surface, on the joints. Okay. Mainly the wrist joints, the ankle joints, or the knee joints.
So mainly on the small
Wrist
joints
and
of
the ankle joint.
fingers, wrists, and the ankle joints.
The wrist and the ankle joints were primarily involved. No knee joint involvement.
Sir, it was knee joint complaint was present before, but in the current episode, she has no knee
She
joint.
doesn't have. So primarily wrist and didn't have any early morning stiffness of the
So
joints.
she did have morning
She did
stiffness.
have. Okay.
This lasted for about 30 minutes to 1 hour,
Okay.
and
So that
later on,
may go in favor of an systemic
inflammatory
onset
cause of
juvenile arthritis. Okay.
arthritis. Yes, sir.
Fine. So she had a bilateral distal interpharyngeal and proximal interpharyngeal joints of all digits. Fine. Okay, so there is a small joint, basically a small joint involvement. And, so only the wrist and yes, but the wrist and the ankle joints are also involved.
Both
Okay,
small and large joints are there. So polyarticular representation was present.
so polyarticular presentation is there. Okay, okay, go ahead.
So this is a 14-year-old female child who
14
has,
year old child, okay, 14 year
yes, sir,
old girl,
sorry, 14-year-old girl who has
okay,
generalized weakness in 7 months, joint pains
okay,
in 6 months, history of fever, rash, and swelling around the eyes, and blood in stools, which was 3 months back. And now she has progressive pallor with anemia that required blood transfusion and oral ulcers with no significant birth or developmental history. This is what we discussed in the history part. On examination, my positive findings are pallor, sparse hair, post-auricular hyperpigmented rash, hepatosplenomegaly, swelling and tenderness on small joints of hands and ankle joints.
okay.
So
So,
based on the
okay, fine, fine. Go ahead, go ahead.
so sir, based on the above findings, I would think of a superimposed autoimmune hemolytic anemia that could be associated with the uh, condition like an SNE.
Mhm.
Or it could be, again, it could be juvenile dermatomyositis as we discussed, because hepatosplenomegaly can be present, um, both either due to anemia or due to the disease per se. It could be present in that. Then small vessel vasculitis is less likely because it does not present with hepatosplenomegaly. And GI tuberculosis, I would keep it lower down because there was no lymphadenopathy that I could find. There was no respiratory involvement that I could find. And sir, one thing that I forgot to mention is there's no contact history of tuberculosis also. Then, as we discussed in the previous slides, inflammatory bowel disease, we could still consider one of the differentials. I would take it above JDM. That inflammatory bowel disease could be one of the conditions. Um, then
Okay, I wouldn't
other
really consider JDM would be a diagnosis where I would see it in smaller children.
yes,
They
sir.
may have an sort of an myopathy, more
Yes,
or
sir.
less, a heliopter rash over the
Heliotrope rash.
eyelids. Uh, they may not have so much of an arthritis. They
Yes,
have
sir.
primarily myositis and
Yes, sir. Proximal muscle pain.
proximal muscle weakness. Okay. They may have definitely oral ulcers. They have, and they may get joint pain, but they don't get a lot of arthritis, but they have some amount of an muscle weakness, muscle tenderness.
Yes, sir.
So, and the age, if I am correct, I don't see a lot of but whatever age group we have seen of JDM are smaller
5
children.
to, yes, sir,
So
around 5
14-year-old would be so SLE might be a little more
earlier.
probable first diagnosis. Rheumatoid, what about rheumatoid arthritis? Why not a polyarticular juvenile rheumatoid arthritis?
So because in rheumatoid arthritis, the DIP is classically spared,
Okay,
and also there are joint erosions,
but you would
which
not
could
clinically,
lead to
how would
so
you figure
deformities.
it
There
out?
is never a
Joint erosion,
deformity
yes.
with
So you with a long-standing Six
Yes, sir.
months, 7 months duration of illness, you might find some amount of deformities with
Yes,
the
sir.
long-standing juvenile arthritis.
Yes, sir.
Okay, I think it looks more logical to put a sort of a collagen vascular disorder,
Yes,
whether
sir.
it's an SLE, it is an juvenile dermatomyositis. You should definitely consider vasculitis. So
Yes, sir.
lot of times we get biased with TB and other infections, but it finally once we rule out these conditions, we know that these children may have vasculitis. So it's very
Yes,
important
sir.
to look at the vasculitis. Before we move to the, I would just answer. There are some of the questions. Somebody has put we have dealt with why negative history of seizures, then how to explain the fever. So it can as a part of whether infectious illness, as a part of collagen vascular disorders, as a part of autoimmune disorders, you can get fever. So fever is not really very sacrosanct for the infectious diseases. Okay, so you can get fever in lot of inflammatory or non-infectious conditions.
It could be a
Then
superimposed viral infection also on a long-standing chronic disease.
yes, she could have some other super. Then she is in any anemia case.
Yes,
Okay,
sir.
so they have, she has mentioned about why you can get these features in anemia case. Yes, you can get these features. That's what we're trying to look at, the type of anemia. It doesn't look like primarily this is a nutritional anemia. So you can have definitely, but you will not get a hepatosplenomegaly
With
with
nutritional
so
anemia.
much of so many ulcers or fever with the nutritional anemia. So whenever we see a nutritional anemia, be it iron deficiency anemia or be it a B12 and folic acid deficiency, who may need blood transfusions, but they are not so sick. They may not have so long duration history. And then answer definitely comes from overlaps. When we look at the type of anemia, we see they have an iron deficiency anemia or they have a dimorphic anemia, especially in vegetarians. They can have both a combined iron deficiency and a B12 deficiency. So your labs would be a clue. Once you see their CBC, MCV quite high, more than 100, you might think of this as a macrostic type of anemia. Then somebody has put a question, why not celiac disease? Yes, any long-standing anemia, you
Iron
should think
deficiency
of
anemia,
celiac
skin
disease.
conditions. Yes,
Yes,
it
but
could be one
celiac
of the
disease is
definitions.
not, she can't present for the first time with celiac,
Mm.
but you have even adults who are being diagnosed for the first time with celiac
Yes.
disease. So celiac is a good possibility, but ulcers, hepatosplenomegaly,
Hepatosplenomegaly. Yes, sir.
very
Joint pain cannot
unlikely.
be
Joint
explained by
involvement
celiac.
in a celiac disease would be a little unusual. So, which will not happen unless and until this child has what I call as a common variable immunodeficiency.
Mm.
So if this child has a common variable immunodeficiency, she can have splenomegaly, anemia, they may have a manifestation of celiac, or they may later on develop diabetes. So, but that will be little down on the list.
Mm.
Okay.
Yes,
So
sir.
I think I have answered. Let me see if there is one more question. Somebody has put a question. TB can have rash and chronic diseases can lead to aphthous ulcers. Uh, Yes, TB. See, TB doesn't have a typical maculopapular rash or an sort of an rash of seborrheic dermatitis. You can get a lupus vulgaris of the skin TB. That's a
Mm.
little isolated patch on the skin where you need to do a biopsy, and the biopsy will tell us that this is lupus vulgaris, but it doesn't give a very sort of a discrete rash. Then somebody has put a question, can anemia present without pallor?
Yes, sir. I would like to answer this, sir.
Okay, go ahead.
Sir, so pallor is not a very reliable sign for anemia. Because it can depend upon the skin pigmentation, and it
Yes.
all can, if the patient is having vasospasm because of any reason, then also
Okay.
it can give a false reading.
Okay.
And yes, that's
So icterus in anemia is a little different thing. There too, if you are having icterus as well as severe anemia, it's a little. There are these two confounding factors which come into play. So you may not be able to decipher the exact severity of anemia if you have icterus. Somebody has again put the question that episodic pain or continuous pain, how to approach the joint pain.
where
So,
I would like to answer.
okay, go ahead.
Joint pain, always we have to see whether it is articular or extra-articular. So if
Okay,
it is extra-articular, then it could be like a pain amplification syndrome, or it could be somatization disorder, it could be, or in the growing children, there is something called as a growing bone pain or growing pain, which is quite common and does not need um
oh,
intervention or evaluation. Then, if we for the articular pain, we have inflammatory causes and we have non-inflammatory causes. So, sorry, sir, I'm
okay, fine.
confusing
Most
with
of the
with the
time we have been telling about the growing pains over all these years, but we know
these are
that now
non-inflammatory.
vitamin D deficiency is quite common. So
Yes,
if
sir.
we treat their underlying severe vitamin D deficiency, most of the children they are relieved of their pain. But there are still subset of children who have normal vitamin D
And
deficiencies
still can have pain.
who can have growth because that's
Yes,
because of their bones are growing at the
yes, sir.
metaphyseal ends, they are growing, so they may get growing pain.
Yes, sir.
Okay. So, but we don't know. I will not be able to tell you exact pathophysiology of growing pain. Possibly we have some other etiological factors which possibly we don't know. Somebody had put a question: does have thal minor flushed hands? So there is nothing. I don't really see that thal minor is nor and is more of a normal individuals can be diagnosed with thalassemia minor. It is not a, it's just a trait basically. So about 5% of the daily population may be having a thal minor gene genetic defect. So it's just because of the routine screening. If we get their HbA2 levels done, if they are more than 3.5%, then we may classify such children or adults as thal minor. But it is very important that all pregnant ladies should, at least in the North Indian population, should be evaluated for thalassemia as a part of pregnancy protocol. Go ahead. So let's move to the what we're left with.
Sir, investigations. So, sir, these are the investigations which were done before the admission. So,
Okay.
sir, hemoglobin was 9.6 gram per deciliter. This was after she had received 2 units of fagged red blood cells. And
Okay.
before, the hemoglobin was, as a mother reported, it was critically low. But how much low the
So
number she
we
does not
don't
know.
have the hemoglobin pre-illness. Do we have
Pre-transfusion,
any
yes, sir.
record of what it was when they transfused her blood? Do we have those records available?
Sir, I'll have to check again.
So
Um,
we have to make sure that you may ask verbally
okay.
to because definitely the parents will know. You can ask them. Any intelligent parent will tell you, "जी 5 gram hemoglobin tha or the hemoglobin was 6."
Mm.
Because only you will not transfuse at 9 or 10. Okay, you
Yes, sir.
transfuse if it is below 6. Okay,
Yes,
for
sir.
a severe anemia which is not responding to oral iron therapy or
Yes, sir.
any other therapy, then you will transfuse. Okay,
Yes, sir.
so you are getting hemoglobin is low, TLC is on the lower side, platelets
Yes,
are okay,
sir.
and you are getting microstic hypochromic anemia. Okay, so still she could be iron deficiency. Okay, so what is the feature of an autoimmune process?
Sir,
So
in autoimmune hemolytic anemia, we
go
would
see the let's
say
see the investigations.
it's
Do we
Okay.
have the investigations?
Yes, sir. So I would skip to what we had done
Her
here. So,
HbA2 is high.
yes, sir.
Her HbA2, no,
Yes, sir.
5.1%. So
5.2, more than 4.
she HbA is more than 3.5. So she is by all standards thalassemia minor.
Thal minor. Yes, sir.
Okay, and the mother is an HBD
Also
Punjab.
a carrier.
She is a carrier. She is a thalassemia and she is a HBD Punjab.
Yes, sir.
HBD is, but HBD is okay.
2.7.
That's like an fine. And what about the father's HPLC? Do we have the father's HPLC?
No, sir. Actually, they are traveling for the
Okay. So
treatment.
mother is
They
a minor. Definitely mother is a minor. That's why the child is also a minor. So this is a
autosomal
thalassemia
recessive in it.
minor. So that's why her hemoglobin will never improve more than 10,
Yes, sir.
maximum 12, whatsoever do. So
Yes, sir.
even she has a concomitant iron deficiency anemia, you correct the iron deficiency anemia. So we will not expect the hemoglobin to go beyond 12
Well,
at any point of time. So that's true of all thalassemia minors.
yes,
Okay,
sir.
fine.
So, sir, these are the investigations which were done at our institute,
Okay,
where her pre-transfusion hemoglobin was 4.9,
okay,
platelet count was very low, 55,000,
okay,
hematocrit was 16%, RBC count were also low.
okay.
If it was iron deficiency anemia, RBC count would have been higher. Um, sir,
Why iron deficiency anemia RBC have been higher? 4.9, I would it corroborates with a very low hemoglobin, your RBC count will drop.
yes, sir. Okay, yes, sir. Sorry.
Okay.
Yes, sir.
Only thing is, see what you do, had it, this is a dual picture. You are getting this child has a
Yes, sir.
thalassemia trait
Yes,
as
sir.
well as an iron deficiency anemia.
Yes,
Okay.
sir. Yes,
So
sir.
if I were to differentiate between thalassemia trait and iron deficiency, but this is a mixed picture in this
Next picture.
scenario. So my Menzer index
Menzer
may
index.
not be really applicable at this
Hmm.
point. Okay. So this is a dual, both she is
Hmm.
getting iron deficiency as well as from your investigations, it seems that this child has thalassemia minor, thal trait.
Yes,
Okay,
sir.
so the RBCs are quite okay with in
Yes, sir.
confirming with the low hemoglobin.
Yes,
Okay,
sir.
hematocrit is also low. So
Yes,
this
sir.
is an definitely anemia. This is an iron deficiency
Iron
anemia.
deficiency.
But your reticulocyte count total is seemingly high, but
Yes,
corrected
sir.
reticulocyte is normal. Okay.
Yes, sir.
Okay. But on the peripheral smear, you are getting now a
Next
mixed
picture.
macrostic microstic picture. Okay.
Yes, sir.
So what were her vitamin B12 levels?
So
Would you
vitamin B12 levels were more than normal because she was receiving
normal?
multiple OPD on the OPD basis. She was being given
Right.
multiple supplements in view of
What
the
was the
panel.
MCV? You don't have put any, once you had put mixed macrocytosis, you should have looked at the MCV also.
Yes,
So
sir.
all red cell indices are important. So you should have looked at MCH, you should have looked at MCHC, you should have looked at MCV. Because
Yes, sir.
for this child, if
Yes, sir.
MCV more than 100 would
Yes, sir.
qualify as
Macrocytosis.
macrocytosis. Okay, fine. Go ahead. So you are getting a mixed picture of an iron deficiency anemia and an hemolytic anemia.
Hemolytic
I,
anemia.
so I will not be able to exactly vouch that this is a purely iron deficiency or a hemolytic anemia.
Yes, sir.
Okay, but with pure iron deficiency, platelets should not go so low.
Yes, sir.
Okay, so that tells me no, this may be an underlying hemolytic anemia.
Hemolysis.
Hemolysis is going around. Okay, so there are so many factors. She has a thalassemia minor that doesn't anyway affect the platelet count, but it affects the hemoglobin. Okay, it will affect the RBC. The reticulocyte, total reticulocyte count is okay.
Yes, sir.
The corrected is high, but the corrected is, why is this discrepancy?
Sir, because reticulocyte count is always seen in with percentage of the total RBCs. So if
Okay,
the patient has low RBCs, then the retic count will look more. So that is why we take a
to a
percentage of the
corrected reticulocyte
yes,
count.
yes, normal
Okay,
hematocrit divided by the um,
Fine.
Patient hematocrit divided by
The
normal
corrected
hematocrit.
reticulocytes. So there is not enough of an reticulocytes occurring in the peripheral blood. Okay.
Yes,
So
sir.
once you give them iron, okay, so they will start regenerating a lot of
Yes,
reticulocytes.
sir.
Okay, go ahead. Next.
1 second. My slide is not moving.
Okay, it's okay. I can. Fine. Anyway, is there anything? What about what was the confirmatory thing you said about
So
the
the ANA
hemolytic
test,
anemia? What was
so the
how did you make the
LDH,
diagnosis of hemolytic anemia?
so the LDH levels were elevated. LDH can
Okay.
be one of the signs of
B12
hemolytic
can
anemia.
also lead to high LDH levels.
Yes, sir. Even rhabdomyolysis can lead to high LDH
High
levels.
LDH
So if you
levels.
just give me
Okay.
1 second, I'll just fix this and 1 second, sir.
I am reading the questions in the meantime. We have discussed with the episodic pain. We have discussed, somebody has told about the thal minor has, then somebody has put hemolysis, retic count should have been higher. Okay. So I do agree with the retic. That's why we do a corrected reticulocyte count. Okay. So here the corrected reticulocyte count is okay. It is normal. And classification of pallor, somebody has put classification of pallor. So classification is still the clinical mild, moderate, and severe pallor, depending upon the severity of the pallor. That's how we grade them. You can very well make out severe pallor with the clinical expertise. Over the years, you see a lot of children with anemia, and you know who has. You can in fact say, no, this may be less than 6, or this may be around 10, with the seeing the conjunctiva, seeing the appearance of the tongue, seeing the general appearance of the skin. Okay, are we back on the slide? So you are saying that her anemia, I can read it for you. And the serum iron is low, 38, okay? And your haptoglobulin uh,
So haptoglobin is
is low.
low.
That supports hemolysis, okay?
Yes, sir.
Then your HPLC suggestive of beta thaltrate, we
Beta
have already
thalate.
discussed.
Yes, sir.
There is no significant bilirubin elevation. Total and direct is little on the higher side, but total is normal. Huh? So your
Yes, sir.
direct bilirubin has to, if you are 20, what is the ratio between direct and the total bilirubin?
20%, sir. If it is
20%.
the direct bilirubin is more than 20% of total, then that indicates conjugated
So here
hyperbill.
we have more of an unconjugate hyper.
Unconjugated.
That happens with hemolysis.
Yes, sir.
If this child is having some type of an hemolysis, hemolytic anemia, the unconjugated fraction would increase. So your SGOT-PT is little barely elevated. So I would,
Yes, sir.
25 is the upper limit, 38. So that's not really. Alphos is low. Why is the alphos low? Alkaline phosphatase. Why
So the
not high?
bone,
Is she having
because there's
some?
no cholestasis,
Okay.
it
Oh, does she
and
have?
it
If there
also
is
indicates
rickets, if
osteo.
there is osteomalacia,
Yes, sir.
the alphos has to be high. It
Yes,
is
sir.
low. Why?
So because the alphos, I think, indicates the osteoblastic bone active
Activity.
activity. So
So is there low osteoblastic activity?
could be, sir, could be a part of the
We'll
constitutional.
have to look. I don't have a valid reason at this
Yes, sir.
point. I will look for the what is the, so go ahead. Anything else left out?
So she had a subnephrotic range of proteinuria.
Proteinuria. So she
Yes,
has
sir.
an around total urine output
570.
3,024 hour is around 370. What is the urine protein creatinine ratio? Do we have that?
But it was more than 2. I have not added it
That
yet.
is significant. Okay. So
Yes, sir.
there was a little, not the nephrotic range you mean she had. So that means if this is a significant proteinuria, so we should really, if we are thinking of an SLE, she could have a nephritic involvement. with the proteinuria. Okay.
Yes, sir, definitely.
To what class it goes, we need to do a renal biopsy for that.
Biopsy.
Okay.
Yes, sir.
Fine. Next.
So coming to the autoimmune workup, her
Okay.
ANA was positive in the titer of 1 is to 80 with a homogeneous pattern. The complement levels were low, and leucose anticoagulant test was negative.
Okay.
Coming to the infective workup, she was worked up for tuberculosis, MAN2 and TB gra were negative, and
Okay.
mycoplasma pneumonia was done, and that was negative. So one thing that I forgot to mention over here is that her DAT was positive. DAT was positive for IgG, IgM, and C3.
Okay, so direct agglutination test is positive. So
2
that is
plus
suggestive of some
positive
amount of an hemolysis is
hemolysis.
occurring.
Yes,
So
sir.
the antibodies are present on the red cells.
Yes,
Okay.
sir.
So if they are present on the red cells, the direct Coombs test is positive.
Yes, sir.
Fine. So did we do an ICT also for this? No. We didn't.
No, sir.
Okay. So your complement levels are low. So
Yes,
what,
sir.
what does it mean? They are being utilized.
Consumption of
The
complements.
complement is being utilized in the process of this inflammatory process. The
Yes, sir.
complements are being utilized. What about
Yes,
the,
sir.
have we done any IgG profile, IgG, M or
Yes,
A?
sir. Yes, sir. Immunoglobulin profile was done. Um,
What about what happens? What would have you expected at the IgG? Would it be high or low?
Higher. Yes, sir. It
High.
is higher.
Any type of an autoimmune process, any type of an collagen vascular disease, TBs would drive the immunoglobulin IgG high up.
Yes, sir.
Okay. So you will have a sort of an monoclonal antibodies would be
Yes,
present,
sir.
would be elevated.
Yes, sir.
Lupus anticoagulant was negative.
Yes,
Okay.
sir.
So you were thinking of what? APLA syndrome.
Yes, sir. Could be possibly.
So your APLA is negative.
Mm.
Did we do a C ANCA or a P ANCA, or it was not
So
warranted?
those lab results were awaited. They had been
We are
sent, but
awaiting. So
they,
why do we
yes.
do C ANCA, P ANCA in such conditions, such children? So what
Sir,
will you tell us? What does C ANCA tell and what does P ANCA tell?
so
So
the
C ANCA is
small
the
vessel.
cytoplasmic ANCA and P
Yes, sir.
ANCA is the peroxisomal ANCA.
Paroxysmal. Yes, sir.
Okay. So
So they could. Uh,
what is present in SLE? What is elevated in SLE?
Sir, ANA titers are elevated. Anti-dsDNA is specific. Anti-Smith is specific for
Okay.
SLE. Then this dsDNA is also
Will the
correlates
C
the
ANCA be
disease
elevated or
activity.
P ANCA elevated?
I'm not sure, but I think
Okay, so
C
you
ANCA
should
is
check with
elevated.
the rheumatologist. So what is, so do we have the, so we can have the audience feedback. Okay, fine. So anything else? So there are, I think we have answered most of the questions. I will still re-look at if I have left out. Somebody has about the ENA. So somebody has asked that about the painless versus painful ulcers. So had it been really infective type of ulcers, aphthous ulcers are painful ulcers. Ulcers due to enteroviruses are very painful. Coxsackie virus, foot and mouth disease are painful ulcers. But children with SLE, with other these collagen may not have really, they are not that painful ulcers. So it's just the physical examination that you note that they have ulcers. Okay.
Yes, sir.
Otherwise, they are not that painful in SLE, if I'm correct. And then somebody has put about the ENA. So you can look. So what should we do? Should we do a ANA or a ENA?
So we should do an ANA, and if the
First thing is that we should
ANA
do
is
a
positive, then
ENA.
we go
Yes.
forward to do
Then you
ENA.
look at the ENA. The first screening test for such children is doing an ANA, that too with an immunofluorescent assay. So you
Yes.
should not do an ANA with an ELISA technique. So most of the time, most of the labs do ANA with the ELISA technique. So we specifically ask them, have they done the ANA with the immunofluorescent assay? So why did this patient have ulcers? So the answer is very simple, because possibly this child has SLE. So if I'm correct,
Mucocutaneous
then that's
part of
why
the disease.
mucocutaneous ulcers. So how many mm, uh, criteria does this child suffice that he had, and this child had SLE out of the 11 criteria? So you
So
have
she had
11
ANA
set
positive, which is
criteria.
the entry criterion.
Okay,
Then one would be joint pain,
okay,
oral ulcers,
okay,
rash, although it
okay.
is not typical, but still presence of rash. Then, sir, weight loss and other constitutional symptoms. No, sir, weight loss is not
No,
one of
they
them.
would not be in
Um,
those
and
criteria.
yes,
They
sir.
are the American College
Muco,
of Rheumatology criteria. There are 11 set criteria.
yes, sir.
So if they have ulcers, if they have ANA positivity, if they have severe anemia, they have thrombocytopenia, they
Yes,
have
sir. Leukopenias.
leukopenia, okay? So you have to have at least 4 of these set 11 criteria to
And
call
one should
this
be
child
clinical.
as an
Yes, sir.
SLE. So
Yes,
you
sir.
can, most of the textbooks will give you these, the American College of Rheumatology criteria for SLE. So you should know these criteria so that you can just decide what this child has. Anyway, I think let's stop. I think I have answered most of the questions. So these are classification. Do you need them to diagnose SLE? Yes, I have. We have already reiterated that you have to have the set criteria for the diagnosing SLE. Okay. So once you meet these criteria, 4 out of 11 criteria, then we do diagnose this child as SLE. So thank you, Dr. Vasudha. I
Thank
think
you, sir.
you did a good job to put this everything in perspective. So we have still 26 participants left. We had 41. Uh, so the dropout rate is just about 50%
50%.
only. Thanks a lot. So my supporting team from the IAP, from the ICH, I'm thankful to them. Every Wednesday and Thursday, they are here to help us out. Thanks a lot. Fine.
Oh, thank you, sir.